name is Dr. Wakas. Today we will discuss about ankylosing spondylitis. Ankylosing spondylitis is chronic inflammatory seronegative arthritis. It is characterized by progressive stiffening and fusion of axial skeleton, and patient presents with low back pain with morning stiffness. Ankylosing spondylitis is common in young adults in second and third decade. Although the cause of ankylosing spondylitis is unknown, it is believed that genetic and environmental factors play a role. Approximately 85% of people with ankylosing spondylitis express the HLA-B27 genotype. It means that there is a strong genetic association. Initial symptoms are usually chronic dull pain in lower back or gluteal region, and it is combined with stiffness of lower back. In ankylosing spondylitis, patients often experience pain and stiffness that awakens them in the early morning hours. Also, pain is worse with inactivity while it improves after exercise. As the disease progresses, loss of spinal mobility and chest expansion with limitation of anterior flexion, lateral flexion, and extension of lumbar spine are seen. Extraarticular manifestation of ankylosing spondylitis include anterior uveitis, conjunctivitis, aortic regurgitation, mitral regurgitation, and conduction defects, apical upper lobe fibrosis, pulmonary hypertension, and cor pulmonale. Other manifestations include fatigue, prostatitis, plantar fasciitis, Achilles tendinitis, amyloidosis, osteoporosis. In ankylosing spondylitis, diagnosis is clinical and further confirmation is done by imaging. MRI is the most sensitive test for detection of early disease. The earliest changes demonstrable by a plain X-ray shows erosions and sclerosis in sacroiliac joints. In later stages, calcification of ligaments with ankylosis lead to bamboo spine appearance. CBC shows normocytic anemia. During acute inflammatory periods, people with ankylosing spondylitis may show raised CRP and ESR. But remember, some people with ankylosing spondylitis have normal levels of CRP and ESR despite experiencing a significant amount of inflammation in their bodies. Positive HLA-B27. But remember, this is not diagnostic. There is no cure for ankylosing spondylitis, although medication can reduce symptoms and progression of disease. NSAIDs improve symptoms of disease by reducing pain and inflammation. For patients whose symptoms are refractory to NSAIDs, tumor necrosis factor inhibitors are alternatives. These include etanercept, adalimumab, infliximab, golimumab. Sulfasalazine is sometimes used for peripheral arthritis, but it lacks efficacy for spinal and sacroiliac joint disease. Other DMARDs such as methotrexate do not have evidence to prove effective in ankylosing spondylitis. Local injections with corticosteroids can be used for certain people with peripheral arthritis. Physical therapy is important for maintaining function and it is indicated for all patients. Patients obtain a significant reduction in symptoms after exercise. In severe cases of ankylosing spondylitis, surgery can be an option in the form of joint replacements, particularly in knees and hips. Surgical correction is also possible for those with severe flexion deformities of spine, particularly in the neck, although this procedure is considered very risky. Bath ankylosing spondylitis disease activity index is a validated diagnostic test which allows a physician to determine the effectiveness of current drug therapy or the need to institute a new drug therapy for treatment of ankylosing spondylitis. Score of 4 or greater suggests suboptimal control of disease, and these patients are usually good candidates for change in their medical therapy and may benefit by treatment with biologic therapies. About diagnostic criteria for ankylosing spondylitis and Schubert test, you can consult my YouTube channel. Like and subscribe our channel for next coming videos. Thank you.